and thank you for being here. I know that I'm between you and the airport to get home, so I'll keep this short. We'll stay on time. It's one thing that I've learned in my experience. So, wanted to give a presentation on welcome. Come on in.
Clinical access manager?
Yep.
Oh, yeah.
Wanted to give a presentation on a program that we're running within Sutter Health. Kind of go over some introductions of Sutter Health, and then our department and what we do. So we'll kind of move on. All right, my name is Curtis Farley. I have an MBA and a BS in finance. I have 7 years of HTM leadership experience, and prior to that, 10 years of general operations leadership experience. My greatest joy, though, is my 6 children. So I included a picture of them here. They are a rambunctious group, and we have a lot of fun. So, all right. So what's Sutter Health? So Sutter Health is a conglomerate of many hospitals and medical office foundations. Some of the facilities date back to the 1800s as the independent hospitals started to open within Sutter Health. There's a story about a Sutter Health facility in Sacramento helping the gold rush miners, and that's kind of how a lot of this started. And if we look at California, we have distinct areas between the Bay Area, the San Francisco area, and then the Sacramento Valley. And in doing so, there's some distinct qualities of each. Cost of living up in the Bay Area is about like this, and then Sacramento Valley area is about like this. So Sutter Health started with a merger in 1996 of the California Healthcare Systems and Sutter Health. California Healthcare Systems, CHS, was comprised of a lot of the Bay Area, San Francisco hospitals and medical foundations. And then throughout that, we've just kept adding and adding and adding. We have one facility that's about an 8-hour drive north, close to the Oregon border. That's kind of that outlier that you get to maybe once a year, twice a year, that kind of thing. But we have a team of individuals that staff that hospital. And our healthcare delivery model is not for profit. All right, so Sutter Health's mission and vision, you can read that. It's to enhance the well-being of the communities you serve through a not-for-profit commitment to compassion and excellence in healthcare services. What's great about this is that in our leadership meetings, we start each leadership meeting with the Sutter Health mission statement and then our own EQUIP mission statement. And this is our network, 5,500 physicians, 24 large hospitals. Here, 4,300 beds, 5 trauma centers, 53,000 employees, ambulatory surgery centers, not attached to the hospitals. And then you can see here, 5,000 volunteers and whatnot. And 426 medical office buildings that are standalone medical office buildings. So you can imagine how much work goes into that. Anybody here from other healthcare systems? All right, welcome. So recently, we were able to open up 2 brand new hospitals in the San Francisco area in 7 months. Now, in California, there's earthquakes and fires and rain and mudslides and all this kind of stuff. And so what California did is say, well, by the year 2030, all of your hospitals have to be seismically retrofitted to withstand earthquakes. So instead of retrofitting our existing hospitals, we decided to build 2 new ones. One's right at Van Ness and Geary, downtown San Francisco. I don't know if any of you have been there, but it's, I want to say it was $1,000 a square foot or something like that to build that out. So it cost roughly $2 billion to build that hospital. And this is our new Mission Bernal campus. This is the old hospital. And then right next door, we built the new hospital. Beautiful inside and out, all new fixed iron MRIs and CAT scans and whatnot. Yes?
You said it was $1,000 a square foot because it was
downtown San Francisco.
Okay, so that's downtown.
Yep.
Okay.
Yep.
Has it been, is it a little bit more advanced because of the regulations that were.
It is.
Stipulations put in place?
Yeah, so there's some of the facility retrofits that they are required to put in is that the building sways. And so if I remember correctly, and Dale Rose is not here, he's our RSM for Regional Service Manager for that hospital. But there's tubes that go throughout the building that actually help it sway. All of the windows are shatterproof, bulletproof.
So they need to put a spring or a roller on the foundation.
I'm not sure. Did they put a roller on? Yep.
Seems in transit of the building.
Yeah. So that's one picture of the Van Ness campus. That's another picture of it. Beautiful. All right, so EQIP's mission. We exist to provide effective, reliable, and affordable clinical technology solutions that enhance excellence in patient care and a safe healthcare environment. So what is EQIP? It's a brand name for the our Center for Clinical Technology Management, but we're also referred to as biomed. So if we look at when they say, oh, call biomed, and some people say, well, what number do I call it? They have to look up EQIP. It's just our brand name. And these are the functions performed by EQIP. We have our operations team. They do our scheduled maintenance, PMs, and our CMs, corrective maintenance. And we have our support staff that handle all of the comprehensive budget management, contract management, and processing of invoices, clinical engineering, incident investigation, regulatory compliance, project management, and then we have asset management, which is the service agreement development on a high level, asset disposition, and then of course capital planning. One thing I will say about EQIP support is back in 2014, we moved from a fee-for-service model to a comprehensive budget management. So we said to a hospital, what do you pay currently for all of the maintenance on your medical devices? And then we took that budget and now we manage that budget. Gives us a lot of opportunities to go through savings initiatives and figure out ways that we can save money because we are the decision makers now on that financial transaction. This is a brief description of our asset inventory. 140,000 total devices, 134 technician support and leadership. And most of the equipment is in-house with support of OEM. I think we have probably about 2,000 service contract devices. And then we have our network, can be networked and non-networkable, roughly about 65% or so. Imaging systems, 35% of our imaging systems are ultrasound. PET, CT, MRI, roughly about 8% or so. And then mammal injectors and rad rooms. All right, so EQIP Clinical Asset Management Program CAMP. That's where we came up with that. We looked at some different options in naming it. First, we were going to call it Sutter's Clinical Asset Management, but then we thought SCAM might be a not so decent acronym. And then we looked at, that's the same thing with our IS department. We call it IS, and it's not IT because Sutter Health IT doesn't have a very good acronym either. But the basic framework began in 2012, and we looked at redeploying a functional medical device within the healthcare system. Great story, and close to its beginning on how this started is we had a very small clinic in a place called Brownsville, and you drive through it, and in about 20 seconds, you're past the main drive. And one of our leaders went up there to evaluate the site, and they drove by, and they said, gosh, I'm at the end of the town. My GPS says it should be here. So when they drove back by, and they were looking left, looking right, drove back by, and they saw a ranger station, or what looked like a ranger station, and then it turned out to be the Sutter Health clinic that was up there. But what we did there was we moved they had an old Bennett Mammo unit that ran on batteries and produced great images, but wasn't digital. And what we were able to do is move a Selenia mammo system up to that facility, saving them the capital expense of, oh, I don't know, $250,000, $500,000, that kind of thing. And even though it only scans maybe 5 scans a week, we were able to give that equipment to them, saving them money and providing a much needed service in that area. We also were able to move a bone density scanner up there, and was a great benefit for the people of that area. But the equipment coming out was still functional and whatnot. So we'll kind of go through some of the benefits that the CAMP program has here. So that aha moment, we looked at cost avoidance, and it was a definite catalyst to implement the program. So we're able to, first and foremost, provide cost avoidance of that capital purchase by transferring that medical device from one affiliate to another. When I talk about affiliates, we talk about the hospitals, the medical office buildings, and the different medical groups that are there. So the CAM program facilitates the moving and then the inventory updates as part of that process. As you can imagine, with 140,000 medical devices, the inventory is always changing. We have plus or minus, 1,000 to 2,000 medical devices each month. And we consult with asset accounting to ensure that the financial information is transferred. We ran into issues where there's been a device that's had $500,000 in residual book value, and they have to take the hit because we're moving it from one facility to another, or we're selling that piece of equipment, and now asset accounting has to take that hit on those ones. And then this is the big topic lately with network security and PHI and whatnot. We ensure the safe handling and then provide certificates of destruction where needed. All right, so 5-step process for disposition. First and foremost, we redeploy. Any medical device that comes into the facility or comes into the warehouses, we look to redeploy that asset elsewhere. Some devices can't or are not suitable for redeployment. If any of you have been to California or worked in California, you can understand how OSHPD, rules at hospitals. So, for example, if we looked at moving a CT, and when we got all the bids and whatnot, it was about $2 million to move that CT. Well, it's makes it not feasible to move that device. Secondly, because we are an integrated budget system, we look at can we harvest those parts and use those parts on other devices when they break down. So don't necessarily have the financial information, but give you a great example on the Selenias. A detector's roughly $60,000 to $90,000 from the OEM. If we're able to harvest that part off of it, well, then we've just saved to our budget $60,000 to $90,000. And then donation. This is the next step. Our preferred partner is VenShare. I just got invited to their annual gala event May 9th, and it's going to be a great experience to see all of the medical equipment that we've donated and see the impact that it's made on the world. Trade-in or sale. We've now gotten to the point where our supply chain partners, if they're presented with a trade-in on the quotes, they contact us and ask for our approval whether or not it makes sense to trade that in for $1,000 or if we can receive greater value going elsewhere. And then lastly, junk is junk, right? We've definitely had our share of junk come into the warehouses, and I'll talk a little bit more about that and what we've done to manage that. All right, so this is our West Sacramento, California warehouse. It's about you can't really see it, but about 83 by 50 or so. We have some different areas in there for part storage. We have some different areas in there for our local BioMeds to store some equipment, and then our floor space, and then our shelving. This is our Fremont warehouse in the Bay Area, roughly about 100 by 50. We have a locked area for high-value part storage, so we can store tubes there if needed, and then go from there. We have it chained off because we do have some of our vendors that have access to our warehouse, and so they're not able to come in here, and they're not able to come in here, but they're able to leave equipment there. All right, so we'll talk a little bit about learning steps as we go through this process. Learning steps are things, those aha moments that you were doing something that may not have made sense, and then you learn from it, and you kind of change and alter that course. So we've had many of those learning steps throughout this process, but one of the main things is it's important to have that accurate inventory information. Because we're budgeted every year, our inventory is a driver in that budget. So, for example, let's say that the hospital was paying $1 million for their repairs and maintenance budget, and their inventory shot up by 50%. Well, obviously, the next year they're going to have to pay a little bit more for that maintenance. And the inventory information also assists in that parts harvest information to know where it resides for our technicians to harvest the parts out of them. See here, we have shelf space. This would be C1, C2, C3. And then, of course, floor space for mobile ultrasounds and all that. All right, so we talked about that learning step. So at first, everybody started emailing me saying, hey, I need this removed. And it got to the point where I was in email jail and could not keep up at all. So we brainstormed, talked with leadership, talked with another healthcare system, Geisinger, kind of figured out how they're doing things, and we decided that we would lean on our in-house programming staff. And this is Harry and Chris, great individuals. We tasked them with building out some type of tracking system for us. And I have their permission, by the way, to use those vendors. So we built a website. Through the website, we can request excess medical equipment to be picked up. We can view devices that are ready to be deployed. And then any devices that you've claimed, you can view the progress on that. And then if there's a wish list, right? So let's say you're thinking one day, I'd really like to have an ultrasound. So you put that on the list, and then you're able to look at that list and get reports on that. And then when an ultrasound becomes available, reach out and go from there. Sorry, I was just taking a picture. All right, so this is the website here. It's an internal website for our folks in the field. But you can see here, this is the submit request. So we'll kind of go through that. It says submit request for equipment removal. And then there's some fields that are required. We're starting to lock down more because we're starting to get or find that that some of the requests just come through and go, hey, I got a bunch of junk that you need to pick up. I have no idea. How are we going to know what size truck to get? How our technicians are going to check it out? Maybe it's 16 roomfuls of junk, and we send a 16-foot truck, so that definitely would work. And then if there's specific information pertaining to that request, what room it's in, contact, alternate contact, that kind of thing. And then this is the email that's sent to us. Basically says here, 2 external pacemakers, good working units removed. because staff got the new ones. And the address, the control number, and model number of them. And this is my dashboard here. We can see right now at the time of this, there was 196 open device removal requests, 214 available devices, and 15 awaiting claim approvals. And this is what it looks like on the remove equipment requests. And so one of the challenges, another learning step, was the communication. And what happens is what was happening was that they'd send in a request, and then they wouldn't know where it was at in the process. And so we changed this a little bit to do status changes. So there's the first one, if you can read it, it says acknowledged, and then dispatched, and then picked up or submitted. Each time one of those status changes, an email is generated to the user and also to the site manager, so that they're aware of what's going on. And when I say site manager, I mean our own equipped site managers. Our structure, we have an administrative director, we have 2 director of operations, Bay and Valley, we have regional service managers, 5 of them, and then we have site managers for most of our large hospitals, and then we also have site managers for our medical groups. So they receive at least notification that says, oh gosh, something's going to be coming out of my facility. And that's what it looks like. It's CC'd to the site manager, and then it goes back to the person. It says your request for device removal has been dispatched. A team member will be calling you within the next 24 to 48 hours when they're on the way to remove the device from your site. And it reminds them, on this particular one, there was one in Sunnyvale, it's in Zanari, that is located in the manager's office. Drivers are dispatched once the functionality check is completed by the on-site technicians. Equipment's brought to the warehouse for disposition process. And if it doesn't have a strategic plan for disposition, meaning it comes in and we don't already know that we're going to harvest the parts, or that's a device suitable for redeployment, then our goal is 90 days in the warehouse, then it's out. We'll talk about the disposition process here in a bit. Before I go on to that, another learning step that we talked about was the functionality of the devices. We got a ton of medical equipment that came in with no record of it. We didn't know if it was working. We didn't know if it was obsolete. We didn't know if there was parts and whatnot. So we changed our process a bit, and I think I have some slides in here to kind of describe that. Then our available inventory, this is for all of the clinical leadership to go out and look at what's available. So right now we have a Carbon XL CR reader, we have a TriStar 5500, we have an OEC 9800, and then it looks like a Logic 9. So they can go in there and they can claim that, and it'll actually show if there's any residual book value. It'll show annual cost of service. It'll show capital acquisition value if they were to buy a new one, and it shows where it's located, and so on and so forth. And these are all devices, like I said, that have been functionally checked out. And then my claims, this is a claim from available inventory, watch list. So this is that learning step 103. They were coming in as non-functional. So we're in the process of implementing a plan to have all the equipment functionally checked prior to inclusion in the camp. So at first, I announced that, hey, I'd like you to interrogate the device, and I'm talking to the technicians out in the field. I'd like you to interrogate the device, give me an idea of what it would take to fix it. And some comments that came back was, I'm not going to sit here and interrogate a broken device and then send it to you and take 2, 3, 4 hours on a broken piece of medical equipment when I can be out going and handling my PMs and handling my CMs and whatnot. So we changed that a little bit. As we're moving through this process development, it's important that we're flexible and that we have that ability to really allow the technicians to do their job, and then kind of keep this as a backup for them. However, having a technician address the functionality, it also addresses the potential of PHI leaving the facilities. I can tell you 10 years ago, I've talked with my predecessor about this. 10 years ago, everybody did their own thing. You know, Susie at Palo Alto Medical Foundation would call vendor A, and then Tommy at another one would call vendor B, and it just got to the point where the potential of PHI leaving the facility became a huge issue for Sutter Health. So now what we're trying to do is lock that down, not have the individual clinical managers reach out to different vendors to sell or give away medical equipment. We want everything to be coming through the clinical asset management program. And it ensures that the device is properly retired. You can imagine if you put yourself in the technician's shoes and they have their list of preventive maintenance that they have to do every month, but they don't know that this has left the facility. They're looking, and then they mark it as could not locate, and then they move forward and they come back and they go, gosh, where's that glass? I can't find it. And so then they continually mark it could not locate, and then it's retired from the system. Well, what if they gave that to the department next door? Then somebody looks at it and goes, gosh, this hasn't been PM'd for 2 years. Well, it's been could not locate. So what we're trying to do is make sure that the inventory is set straight prior to the device leaving the facility, any device. And this is kind of that unnecessary work that I talked about. Junk just needs to be e-wasted to prevent that unnecessary work. So, our reports that can be generated from the website activity. Some examples here, and trying to take a spreadsheet with 25 columns onto one and we make it super small. So I broke out and just did some of the information that's included on our reports. Manufacturer model, control number, the original affiliate that the device was located at, capital acquisition expense, fair market value, depreciation left, age, arrival date, how many days did it spend in camp, date of final disposition, and what was the final disposition? Was it sold? Was it redeployed? Was it donated? Did we harvest parts off of it? Any cost avoidance if we redeployed the device? And then the final disposition, vendor who sold it or traded it in, and does it contain PHI? Any questions so far? All right, some of the advantages to having this program really is that capital expense that our facilities do not spend on new medical equipment. I keep track of it, and over the last couple of years, it's been paying right around $2 million per year. So you can imagine what our supply chain VP thinks about that. They love it. That's less capital that has to be spent on new medical devices, and we're resurrecting life and continuing the life of that asset when we redeploy the units. Greater control of the medical devices leaving the facility, and of course addressing the potential of PHI loss, and then the control of inventory of the active medical devices. Asset accounting, they've been a great partner with us because their goal is to keep the financials straight for the depreciation. Huge advantage to having this program. And we have warehouse space for long-term storage of medical devices if needed. I can tell you in this transition with the new hospitals, we are storing some medical equipment for backups as they kind of move through and make sure all the rooms are fully stocked out with medical equipment. So we have suction regulators, we have airflow meters, we have we have infusion pumps, we have a whole crate full of SCDs. So we're able to store some of those medical devices. And the consultation of trade-in devices is a large advantage of this program as well. I think everybody knows, and I apologize if some of you are partners on the vendor side, but the trade-in value on medical devices is quite a bit less than what we can find elsewhere, even on the sale of medical devices. Another big advantage to having this program is the consolidation of vendors to remove the heavy medical devices from our facilities. We have been able to consolidate, and we've been able to kind of try out new vendors, figure out which vendors we don't want to invite back to our facility. I'll give you a story on that. We have a great, I think he's second generation partner that removes a lot of our radiography rooms, our nuke med. He's even removed CTs and MRIs. He's second generation. His father did it before for Sutter Health, and he's a great vendor to work with. We have another vendor that we had remove a rad room, and they came in with a, not looking professional. They had a car engine hoist to remove some rails from a rad room, and needless to say, it took longer than expected, and they're not invited back to our facilities to perform any of that type of work. So we've been able to consolidate those vendors instead of having each facility go out and reach out and end up with a bad experience from a vendor that doesn't really know what they're doing. All right, so overcoming challenges. So if any of you have been in the process of trying to talk with a large healthcare system, there are so many layers of people that you need to speak with in order to really get the answer that you need. So one of the challenges that we had was selling this program to our internal customers. We have, again, we talked about the differences between the Bay and the Valley. Bay, the cost of living is here, Valley's here, but also difficulty sometimes to change in the Bay is here and Valley's here. So in the Bay, we've done a incredible amount of work to try and sell this program to a lot of our internal customers. We have to provide that verifiable data that shows, hey, we're doing something that benefits the system. Let's get you on board. So I presented to CEOs, CFOs, Bay Area directors, Valley directors, facilities folks, supply chain folks, to try and make sure that they're on board with what we're doing. And now I can tell you every single email that goes to one of our partners at CPMC, which is the new hospital that we built, every time somebody emails and says, hey, I'm looking for used medical equipment, she forwards it on to me. Huge win, and it's been great. But it's taken a lot of work to get there. And then our learning steps, if we think about that straight line and then all the forks in the roads that have come over the last few years, there's an incredible amount of learning steps that we go through, and we're continuing to go through them. That greater communication with automating processes. When we talk about our programming staff, they can do wonders. They're amazing with what they can do on the Outlook side and the internal website side, to be able to route things and to have this all automated to the point where perhaps we can get to the point where work orders are generated for our movers in order to help speed up that process. then one of the challenges is obviously overflow of the warehouses, and then control access issues to the warehouse. We don't want people coming in that have just open access to all of our patient data and all of our medical equipment. This is how the equipment used to come into the warehouse. No inventory, some trash. Not a great picture, I apologize for that. And then after the inventory, the devices are placed on the shelves, placed on the website. You can see that they're stacked nicely. You can really see what you have. And this is our partnership with MedShare. Just wanted to throw that website up there because I think they're a great organization. If you have the chance to ever donate or work with them or volunteer in one of their facilities, I would highly encourage you to do so. And then future developments. So able to sit on a system-wide value management team to identify an e-waste vendor. So as we become more integrated with our IS department, with our affiliate leadership, and we looked at how we can consolidate everything on the e-waste side. So the e-waste is going to include the medical device e-waste, and it includes the IS e-waste as well. So we're looking at putting bins at some of our larger facilities and even some of our smaller facilities, so that if you have a medical device, if the equipped technicians have a medical device at that facility, then they can put it into the e-waste bin. That'll be sorted out at that provider. They're going through contracting and negotiations right now, and then we'll be able to roll that out. Future developments, we're looking at on-site repair of medical devices inside the warehouse once the equipment gets here, so that we can then try and gain some greater value for those medical devices. Really only minor repairs though. If we started doing and fully fixing it, then the hours don't make sense that we're spending towards those medical devices. And then the integration with CMMS, our additional development there. And then loaner program, medical devices. So right now, again, it's very fragmented on where we go for loaner equipment, but if we had specific medical devices at the warehouses that are able to be used as loaners, telemetry units, STDs, another great example would be infusion pumps, and we'd be able to have those loaners there. Probes as well. Probes would be a great one to have. All right, that's it. So I hope that I stayed on time. I'm probably a little bit early, but I definitely want to open it up and give you some time for questions and go from there. Yes, sir.
With such a large equipment group, I know you handle the majority of repairs probably in-house, but there's certainly items that you have an OEM contract on.
Yep.
I'm imagining because of conversations that I get pulled into, you talked about doing the functionality test before you move it.
Yep.
It's covered under an OEM contract, you move it, you get to this new location, and you find out it doesn't work.
Yep.
If I'm stepping in that OEM shoes, which I don't, but if I am, the OEM's going to say it was damaged during your
That's right. So you moved it, so it nullifies the contract.
So is that, yeah, is that
so
an issue you ran into?
We've had that a couple times, but really when it's on a totally broken piece of equipment that, for example, we have microscopes, right, that are under a PM only contract. So the microscope is broken. We need to be able to identify that microscope and cancel the coverage on it prior to move. But for example, like lab equipment, big iron, that kind of thing, we're going to cancel that coverage on it, move it, and then it probably doesn't have a plan to redeploy it. Now, we have had instances where there's been a well, we just moved an MRI trailer that has coverage on that from the OEM. What we were able to do is partner with the OEM, and they were there during the move, and they also use that same rigger service that we used. We paid them, but the OEM was involved in that process. We've also had lab equipment, but typically when we're moving a piece of lab equipment, we're not redeploying that lab equipment. So we would cancel the coverage, move it out, and then either try and trade it in or sell it to an OEM or to a third-party vendor.
Courtesy.
Yes, sir.
We had a couple CTs that we were upgrading. And of course, if you have the 16 slide CT and you're replaced with a 64, we have a couple of 4s left in your system. You sort of want to move that 16 everywhere the 4s were. And Curtis coordinated a lot of the move, and we worked with the vendor so that we were able to move it. And even though we didn't move it ourselves, the cost avoidance of upgrading that machine from a 4 to a 16 was still there. So it just depends on a lot of the size of the equipment. We've also moved some X-ray rooms from one place to another. And sometimes we use the OEM, sometimes we're using a third party. But because of the level of service that our technicians are able to do, they may not do the installation, but after it's installed and on the right, we're doing the service on it.
Yeah, thanks for that.
And what about if you are able to sell the piece of equipment, where do the funds for that? I mean, do you ever run into situations where maybe the doctor is saying, okay, if you can sell this for me, I want to get some of my money back.
Yep.
So how would that whole process
no, that's a great
work?
question,
How does that work?
and I appreciate you asking it. So we're a not-for-profit system. All of our equipment is Sutter Health capital equipment, right? So it's owned by Sutter Health. Now, when we go to sell a piece of equipment, there have been many times where a doctor has said, oh, I'd like to buy that microscope. Well, we can't sell it for less than fair market value due to START and whatnot. So we perform a fair market value from an outside third party, totally disconnected from Sutter Health organization, and they give us the fair market value on that. Then what we do is say, hey, Dr. So-and-so, would you like to purchase this equipment for the fair market value? Sometimes they say yes, sometimes they say no. Once they do, we have OGC approved liability forms, bill of sales, transfers, all that kind of stuff, and then they take the equipment, give us a check, and they go from there. Now, in a situation where does the funds go? So first and foremost, Sutter Health owns the equipment. Now, we can put it back into that facility's general capital fund, but because it's capital, it's not going to hit the individual manager of that site operational expense because it's capital. They don't have a capital budget. The facility has a capital budget. Does that make sense?
Yeah.
So we can direct it to the facility, we can direct it to the Sutter Health Capital Fund, but it's not going to go back to that person's cost center as unrealized business income, right? It has to go capital to their capital fund.
Curtis, give them the figures for that Da Vinci, what we had happening.
Oh, yeah. Yeah, so we had Da Vinci robot, they wanted to sell it, and it moved from one facility to another, and I want to say it was about $500,000 residual book value that transferred from one facility to another, but it didn't hurt their individual cost center. Does that make sense?
It kind of, sort of, but but the funds would not go back to the doctor's office or the doctor.
No. And the way that Sutter Health works is we have independent physician groups. They don't have any equipment. They use Sutter Health's equipment.
Okay.
So then we have clinical leadership, where they manage that department and they manage all the equipment there. And if they want to purchase something, then they have to go through Atenia, they have to submit the request, and then it comes out of the capital funds that are allocated to that facility. Yeah. Yes, sir.
So I just want to, I've used this firsthand. I work with Curtis. My name is Tom Sparrow. I'm the site manager at Roseville Medical Center. Right now, I just sent you an email because as we're talking about this, I'm thinking about one of my surgery centers that is renting 4 vital signs monitors. And so they're working with Agility, paying probably $1,500, $2,000 a month. And there's just so much everywhere where there's an opportunity. And so as we're talking about this, I was remembering a conversation we had last night about you had some more monitors from one of the hospitals that closed down. And so the light bulb's going off in my head, like I could save $2,000 a month for an outpatient surgery center because they don't have the capital to go out and buy all brand new monitors. But at the same time, we can take this and use it effectively.
Yeah, we've got 26 of those, so it'd be great. And if we did that, I mean, you can imagine, you know, if you're renting 4, let's say $500 a month, and we have 26 of them, you know, what's that? $13,000 per month, $150,000 per year that we're saving on rental expense. So I apologize if any of you are rental vendors, but there's some great value to that through this system. Yes, sir.
So do you have any initiatives to reach out and ask if people are renting? So he just told you that he was.
Yeah.
Just because he remembered it, basically.
And so that's actually a good question. About a year and a half ago, we were approached by our supply chain partners, and they talked with us about beds, right? So bed rentals are a huge expense. And I would, you know, I'll just throw out a number of, you know, $1.5 million per year on bed rentals. So what we looked at was, is it feasible for us to rent a large enough space and have the movers available to be shifting beds around? Bariatric beds are expensive. And then what happens is they'll rent a bariatric bed and then they're paying for it, and then it'll get stuffed in some room that's no longer being used, and then, you know, the vendor is going, all right, hey, you just let me know when you want us to pick up that bed. And it's over here, nobody knows about it, and then a year goes by, nobody's touched it. A year goes by and they've paid all this money, and then all of a sudden it's like, oh, we gotta get this bed out of here, right? So same thing with loaner program, right? That's one of our initiatives that we're going to start developing, is how do we look at loaners, how do we monetize that and look at who's renting, how do we get the word out, but absolutely that's on the radar. We just have to be able to properly implement it and then get that information out. Another note is that right now, when I first started this position, we looked at our move expense, right? So we would call Beacon or NorCal or another company, and they were charging us like $1,500 to move a device from one facility to another, or to make a pickup and deliver it somewhere, or that kind of thing. So I came in and I looked at that and said, gosh, we can do that for much cheaper. So reached out and tried out different vendors, move vendors, and was able to get that down to right around $800 to $1,000. And so we saved money there, but in the future, a future development would be to have our own moving service, to where we have trucks and we have box trucks and whatnot. We have employees that can go out and do that move service for us. But again, the dollars have to make sense. So, any other questions? All right, so I'm between you and lunch. I'll let you guys go, and I really appreciate the time to be able to present, and thank you.